Good afternoon, students. We are thrilled to have you here to join us for our last session of the 2021 Youth Security Forum, and it is on health security and health intelligence. I am thrilled that we have our very own local Dr. Jim Wilson joining us today to talk to us about his perception of some of the things that went on with COVID and more generally about health and medical intelligence. So with that, I'm going to turn it over. Before Jim, I give it to you, I'm going to turn it over to Chelsea to make an announcement.
Yeah, just real briefly, we want to thank the sponsors who've made this whole Youth Security Forum possible this year. The Reno Sparks Chamber of Commerce, Mission Support and Test Services, who run the Nevada National Security Site, Ted Morse, Larry Struve, and Norman Janziomek. Thanks for your support.
Excellent. Thank you very much, Chelsea. And with that, I am going to, before we open it up to the students for questions, I'm going to ask Dr. Wilson to step back and give us, they've seen your intro video, but I'd like you to go into a little bit more detail, if you would, on what we mean by health or medical intelligence and security in this context, and your perception of that. And then we'll roll into how that's connected to what's going on in COVID now, what happened in the past, and some recent developments that just came up yesterday. So with that, Dr. Wilson, please.
Okay. Let's see. As far as the situation, so I guess when you use the term medical intelligence, it is used in different ways depending on what agency is using that service. And then that, so from a military perspective, for instance, they use medical intelligence to assess, foreign adversaries' capabilities to mount medical support, during military operations, as an example, right? For the Central Intelligence Agency, they use medical intelligence to assess foreign leaders, right? And how healthy they are and how that might influence negotiations. In my world, I was a bit of a very strange bird, and Maureen can laugh pretty hard about that comment. Is really what I was focused on was, we didn't really have a name for what I was up to. I wasn't the only one to do this work, though. There are other folks who've done this before, and there's a little bit of a reinventing of the wheel going on too, because this work was actually done back in the 60s. But basically, to watch the world for suspicious outbreaks, suspicious epidemics, right? And there's a whole discipline to the provision of warning. So it spans the gambit of, okay, I'm detecting indicators, signs and symptoms of a community that's experiencing a crisis of infectious disease that they have not encountered before, right? That is non-routine, unusual, is perceived to be insurmountable, right? Is clinically significant, like it's killing people. And then translating that initial detection to a warning communication that is actually relevant, that folks will actually listen to. That latter part is actually the harder part of the whole dynamic, and really what I've been up to for the last 25 years. So really what I've very narrowly focused on, maybe too focused, is really the discipline of detection and then the subsequent warning communication. That process is a tricky thing to get involved in, because these types of events don't happen very often. And for all of the concerns about failure to support public health, that is quadruply so, in my domain, right? That it's sort of, if the crisis hasn't happened in a while, then out of sight, out of mind. And then everybody gets upset when we get hit with the next one, and they say, well, why didn't we, invest in that? Well, I mean, it's like turning off your hurricane radar system. Problem is hurricanes actually happen a lot more frequently, and that there's a frequency thing, right? So you have to have a crisis that happens often enough and is significant enough for a society to invest in a proper warning system, where you're maintaining a team of people who maintain corporate memory, right? Who are able to sort of share the lessons learned over time. Here's the good, the bad, the ugly. Here's what we got right. Here's what we got wrong. Here's how we improved the discipline. Have some degree of academics behind it. Peer-reviewed papers, that kind of thing. Conferences, after action reports, that sort of thing, and accountability to the constituents that they serve. So really my world is warning intelligence, right? Which is very, very narrow and very esoteric, I would say. It's kind of like watching for asteroids to hit the earth, that kind of a dynamic. Not quite that
Well,
bad.
maybe, actually on that notion, perhaps it would be less esoteric if you gave us some concrete examples of what specifically you were looking for in terms of warnings. Take COVID. When did you see it? What were you looking at? What did you see and when?
Well, that COVID was pretty darn easy, honestly, in the beginning. And the way these things start off, they start off always with that innocuous first report. The report that you look back in hindsight and say, goodness, that was the beginning. It looked pretty ho-hum in the beginning, but they always look ho-hum in the beginning. If you catch it early enough, right? The first, what we saw was just a local media report that just came across our email distribution, and we opened it up. It was in English, and we knew that if it was in English, it probably was a delayed report, because that's pretty classic. But it was a report talking about a couple dozen cases of unusual respiratory disease that were hospitalized in Wuhan. No fatalities, no healthcare worker infections. And at that point, you sort of say, well, why is this even a media report then, right? Because you're talking about billions of people, over in Asia. They see respiratory disease all the time. And on December 30th, that's right in the middle of their flu season, right? So, so it's the fact that it hit English media, that's a point of significance right off the bat, right there, right? Is we don't really get a whole lot of traffic over on the English side, for just routine respiratory disease, right? So that's kind of one level of eyebrow raise, if you will. But they talked about it in terms of an unusual respiratory disease, that was concerning, right? And that's another level of, okay, you got my attention, right? But I'm not going to panic, because there is a baseline of reporting like that for the planet. So if you watch this sort of thing from pole to pole across 50 languages, you'll see that kind of reporting happens, and you're a little bit stuck. You can tweet about it and say, hey, that's interesting. I wonder what's going on there. But for any major organization, transnational company, government, to pay attention at that level of information, they're not going to really do anything with that. It's sort of like, okay, that's interesting. I'm going to kind of, I'll follow along with you, kind of thing, if I have the mental bandwidth to do so. We did post that we were tracking it as a matter of priority on December 31st. Because I did consider it to be kind of unusual. And so you got to keep in mind that's in context with as many as 5,000 live threads of other stuff going on around the world, everything from cholera to dengue. And I will say that respiratory disease tends to always go to the top of the list for us, because we know that unusual respiratory disease tends to get away from us a lot quicker and is more difficult to control than known disease, than disease that is inefficiently transmitted, right? So we worry the most about respiratory viruses. We always have. And especially China, because we know that there's delays in understanding what's going on in China. And by then it could be in the air traffic grid and spreading all over the planet, as a general rule. So we did post it publicly on December 31st. We gave indication that San Francisco was connected by direct nonstop air traffic to the tune of, if I recall correctly, it was like over 5,000 passengers a month. Then on January 1st, we did notify WHO. We told them that the indicator pattern did not match that of SARS 2002, 2003. So we understood, sort of, how these things are reported. So whatever it was, either we were getting the report way early in the game, which is a good thing, as it turns out to be for China, This was a pathogen that exhibited a different clinical profile, right? That it just wasn't as lethal as SARS. So SARS was 10% lethal. You know, that was the belief at the time, right? Among recognized cases. And here we had a report of a few dozen cases hospitalized, but no one has died yet, right? But you know, it's quite a number of cases, right? So we're communicating, but we're cautious, right? So we tend not to like to jump on the hyperbole bandwagon. And leading into this, for years, we have noticed this trend of media reporting and really public health expert and some of the biodefense expert reporting that everything goes to worst case scenario, you know, that everything is pandemic potential. The word pandemic was being abused. And so there was this tendency, and there was actually a whole industry around this notion of sensationalization of intelligence, really, if you will. And that was bothersome to us because if you do overcall things, you get burned as an analyst, you lose credibility. If you undercall it, of course, you get burned, right? So darn if you do, darned if you don't. But the issue with communication is important, of maintaining trust with the people that are listening to you, right? So if you come in and you're all shrill and hand waving, they're going to dismiss you. They know that you're not a professional if you do that, right? I mean, and when I say that your constituents, I'm talking about people who are in charge of hundreds of millions of dollars of annual revenue, potentially, right? Or a government leader. And you can't behave that way when you're communicating. You need to keep it cool, and you need to keep a level head and be calm. So the analogy that I would give you is, you don't want a hysterical surgeon trying to come in and do open heart surgery on your father who could die on the table, right? You want a calm, you know, almost Mr. Spock-like individual who doesn't have a whole lot of emotion come in and just say, hey, here's what we're going to do. We've done 1,000 of these before. Here's what we know. Here's what we don't know, right? Here's what will likely go right, but here's what could go wrong. You know, I mean, that kind of conversation, right? And of course, none of that was happening. Everything was, you know, everybody's saying straight to nuclear option, worst case scenario, we're all going to die. The species is at risk, you know, and it got ludicrous pretty quick. Now, the penalty of that spread of fear and hyperbole, and where really the foundation of that communication process is uncertainty. So the more uncertainty with these crises, the more that process is enabled to just go boundless, right? What was at stake at the time was the supply chain, right? And so our primary concern was, you know, number one, let's not freak everybody out and promote panic buying and hoarding of critical supplies like the N95s, right? So
and toilet paper.
Yeah, I told jokes about that the last forum, probably, you know, not great humor, but yeah, it got ridiculous, right? And that kind of behavior was something that we've seen many times before with other health security crises. And we knew that was a potential, right? And unfortunately, the media just refused to work with us on that. We tried. We had one media outlet that was pretty good in the beginning, and then they just, you know, went off the deep end pretty quick with it. The other side, which is not even less funny, really, is spreading fear among your first responders. Mm-hmm. If I come in and I say, hey, we're tracking something, we're not quite sure what it is, but it's killing people and they haven't diagnosed it yet. What you don't want is your critical care personnel not showing up to the intensive care unit to man those ventilators, right, and take care of your patients. And if you let this get out of hand, those people, they're people too, you know, and their main source of information typically are the mass media outlets and social media. And so, and then you'll see that they themselves will engage in that hype amplification cycle, and then they themselves are spreading hype and fear. And that is counterproductive when we need to basically go to war, right? And so when we're mounting a warning and we're gearing up to go to war, we do not need that kind of psychology going on. And
so Jim, who specifically were you providing those warnings to? So when you were seeing this information, recognizing you're being very cautious, You're seeing indicators, then you're providing warning. Who were you providing warning to in the early days?
Yeah, that was kind of tricky. So I've done this a few times now. So swine flu was the last, respiratory, crisis that we managed, or that I managed. We used to give it to the government, and the frustration we had is we would see hesitation because they had to engage in all of these other bureaucratic and sometimes diplomatic processes. I mean, it was understandable why they were hesitating, because they had to go and contact, folks through diplomatic channels to ask their permission if they can come in and help out, and help them diagnose things. I mean, there's all kinds of stuff that happens behind the scenes that slows down that communication process. The problem is the pathogen doesn't care. It's already in the air traffic grid, it's already on the move, whatever, right? And so we knew that after our experience with swine flu, that we needed to change the way we disseminated information. We needed to actually give it straight to the critical care infrastructure, which is effectively the front line of defense. It's actually not public health. It's really the intensive care units. And until the day comes when public health has the legal authority to shut down the air traffic grid like that, which I don't think is going to happen. But at this point in time, we knew it was really the hospitals. So therefore, we had the fortune of being able to work with the Nevada Hospital Association. And that was the kind of the belly button of contact for the hospital infrastructure for our state. And so for the first time in my career, we basically just went straight to the hospitals and only communicated with them. We did share information with public health when they asked for it, of course, right? And we did we checked the ethics box by publicly disclosing this was the #1 thread that we were tracking worldwide, right, on December 31st. So we had to check, and we notified WHO. So we had to check a couple ethics boxes, in which, that would be a question to go back to any warning unit or any warning company or any company that claims to have also provided warning, is what did you do to check that ethics box, right? So if you say that you detected it, but you notified your clients, but nobody else knew about it outside of your client list, that's a massive ethics problem for your company, in my opinion. Because when you're talking about millions of lives online and trillions of dollars at stake, that kind of skates out of bounds, for what the right thing to do is, in my opinion. And that's my personal opinion.
That's great. That's really helpful, because you defined that you communicated to the hospitals, but you also communicated to the larger organizations like WHO. So I'm going to pause you briefly, Jim, and ask our students if you have specific questions for Jim to guide his discussion of health security, particularly in the context of COVID or in other topics.
So it sounded like you've been doing this for about 25 years, correct?
Correct.
All right. So did you have to deal with the SARS pandemic when that happened too? I know you kind of talked a little bit about it, but how much did SARS differ from COVID? Because they're both a type of coronavirus. And I know you talked about the mortality rate and whatnot. But if you could dive more into that, that would be a really interesting discussion I'd like to hear.
Absolutely, Cole. So, and it's a great question. So my involvement in SARS was really to do an after action warning failure analysis on SARS. And so what our team did at the time was we looked at Chinese media reporting of SARS-like indicators as an after action, right? So we were trying to evaluate how quickly was WHO able to recognize what was happening and mount a global alert, right? So they issued an alert on, if I recall correctly, it was March either 12th or 15th, 2003. And we were able to find publicly available media articles talking about a grossly unusual epidemic of disease that was killing people going back as far as October 2002. Now, the further you go back, the further you start blending that signal in with routine influenza reporting and cold and flu reporting that's nonspecific. And so it's really hard to sort of say, okay, well, that's what, specifically where it started, of course. So you have to kind of, it's a really squishy signal. So it's kind of like a patient coming in seeing me and they're running a fever. So day one, they come to see me, they're running a fever. Well, good heavens, that could be anything, right? Day two, they come in and the fever's high enough where I'm thinking, okay, could this be flu? And I'm thinking about running a test, right? Day three, they come in, they're running a fever, it's high, and now they have the characteristic rash of, say, measles, right, or some other recognizable disease, some pathognomonic sign, and then you notice that your probabilities and your decision tree starts narrowing down as time goes on. That's exactly what it looks like when you're monitoring these signal patterns, right? So when we looked at SARS, we noticed that there was a whopping signal that was missed in the media going back months before WHO issued a global alert, and several months before some of the the lesser known informal public health monitoring websites had picked it up. So there's a big signal that was missed, right? And what was interesting in the ensuing years is we went back and did case studies on the 1957 pandemic of influenza, 1968 pandemic of flu, MERS, when it emerged back in, I think it was 2012, 1889 pandemic, 1918. All of these crises are all associated with very similar signal patterns, but also very similar shortfalls in human recognition of those patterns and subsequent communication of warning, right? And so what we were doing is we were using these historical examples to teach us these are the signs and symptoms of a possible global crisis emerging, that could be difficult to detect, right? So that was kind of our involvement with that. Now with SARS, looking back on it, it's kind of tricky. You're dealing with a coronavirus. It's different than the one that we're dealing with now. It's in that family of Coronaviridae. But at the time, among the recognized cases, right, it was believed that the case fatality rate was about 10%, right? So that's substantially more than what we're seeing now. But, one could ask the question, okay, well, that's also driven by recognition of the cases, right? So the testing back then and the testing that was available and later disclosed and reported by China, probably we're missing a part of that story, right? I'll bet you there's way more cases that actually occurred back then that we just didn't really know about or could know about. And maybe the Chinese themselves didn't know about it because they didn't have the proper testing available. And you classically will see that in the beginning of epidemics involving novel pathogens, right? They just don't have the diagnostics available, right? And so even if they were a fully transparent society, that's the challenge that you run into, for any nation. Okay. So the irony really with all this, just as a side note, is we had picked up on some interesting media reporting of some nursing home residents that had abruptly died due to a cluster of them that had died due to an unidentified respiratory agent just outside the Capitol, Washington, D.C. And it was interesting to us to kind of sit back and watch how long did it take for public health officials to come back and provide us with a diagnosis of what had happened, right? And it took them weeks. And so the interesting thing here is, we criticize we're very quick to criticize other countries about how quickly can you find out about what the pathogen is that's causing a given unknown outbreak. Well, we struggle with that question on a daily basis here in the US, and so, we got to be careful about, really understanding how do humans recognize what is going on, how long it takes them to resolve uncertainty. With SARS, it spread, but it was interesting. The amount of socioeconomic disruption it caused, sort of at a local level, was a bit more for the initial foci of SARS, but not the subsequent. Now, there were a couple ugly scares, of course, with Toronto, for example, where it got, one case got into the emergency department undetected and wound up spreading in a hospital and darn near shut down their entire critical care infrastructure in Toronto, which is pretty eye-opening, right? So it's kind of like all it takes is one unrecognized case to penetrate the intensive care unit setting, and you can take a hospital offline. If that hospital is your trauma center for the city, it's like a torpedo hit to the heart of your critical infrastructure, and that's a devilish problem.
So Jim,
yeah.
part of my understanding of this is that although SARS was substantially more deadly, it didn't have the asymptomatic transmission that we were seeing in SARS-CoV-2, which allowed the spread to go on, like you said, undetected to wide swaths of the community, much further than when SARS was spreading. It was primarily when people were symptomatic and pretty sick, and the predominant number of people that died from SARS were in the healthcare system.
Yeah, and so the virus hadn't adapted really, right? And so
Mhm.
it wasn't spreading efficiently. And that's kind of we've always worried about that phenomenon, right? But I think part of the issue leading up to this particular engagement was we've always worried about that, but we've gone through multiple crises now where we worried about it and then it didn't really happen, or at least we didn't know it happened, right? So sort of tempest in the teapot kind of moments, right? Now, SARS was massively damaging to the involved countries from an economic standpoint, right? It shut down tourism, for example, and that was a massive economic hit. But it didn't globalize, right? It didn't become the true pandemic. The true pandemic being pole-to-pole exposure of every human being, where you're not really going to escape this, kind of thing. And that's a challenge, right? Because then when you're talking to your lay audience, the decision makers, they say, oh, the last time you came into my office with your hair on fire, we were talking about Ebola in West Africa. And, I distinctly remember you saying and quoting CDC from Time magazine saying we're going to see 2.5 million cases in Africa. And really all we saw was what, a couple tens of thousand? I mean, yeah, that's a big deal for Ebola, but still, we didn't see it here. It wasn't an issue here, and so they get a sense that you're hyping things, right? Zika at one point in that crisis was referred to as the possible next HIV pandemic because it was an RNA virus. Yes, it was transmitted by mosquitoes, but also happened to be transmitted sexually. And then this particular individual just couldn't resist the association or the extrapolation, jumped on the mass media and suggested it could be like HIV. And so it's like, well, okay, great hypothesis, doesn't help, right? Because now that's yet another example where, failed proclamation of doom. And now that makes my job triply harder the next time we got to provide warning, right? So it's this cycle of an inability to strike a balance. So with SARS, it was a natural phenomenon, right? The virus didn't adapt. It was pretty lethal. It was very scary. And frankly, looking back on it, I just feel like we simply got lucky.
And talk a little bit about the difference between what the Chinese government shared during the SARS cases versus what they shared, at least in the early stages of COVID.
Well, so China has had actually a long history of obfuscation, right? They either don't recognize it in their own country, which is actually highly probable, given the eras that we're talking about, right? So when you go back to 1918, we actually don't know where that virus really came from. There's all kinds of hypotheses, but we've never been able to pin it down. It could well have come from China. 1957, there was significant delays in recognition of that pandemic. Basically, WHO first got warning from Singapore, and that was after that particular virus had already spread throughout mainland China, and China never told anybody at the time. 1968, this exact same pattern happened. You had a pandemic influenza strain spread throughout mainland China. They didn't tell anybody. We didn't find out about it until it hit Hong Kong, which was a British, protectorate at the time. And so, the way that we find out about the information is that China just doesn't really disclose, and we find out once it hits a connected site, a site that's connected to China through commerce or human population migration, right? So with SARS, we saw the same basic pattern, is that it started in mainland China, and there's this big time delay, and then it hits a area that is a little bit more communicative, like Hong Kong, and then we're off to the races, right? The Chinese at the time were not very forthright on an official level with the information, but as I shared, the Chinese media was pretty vocal about it, surprisingly so. They said a lot of things that we would have expected them to censor immediately, talking about military involvement and so forth in the response effort. So then when we fast forward to the current situation, what we noticed is that the frame of information was shortened dramatically, right? So with SARS 2002, 2003, they didn't really engage in a whole lot of dialogue until March, right? But yet it probably began sometime in October, November timeframe, right? This time, there's a hypothesis it might have began in early December, late November, who knows? But we're getting the communications out of China, this time in late December. So it's several months worth of improvement if we assume that the time sequence was roughly the same, sort of this October, start point, October, November start point. So
yeah, that's helpful. That's helpful. That gives it. Cole, did that answer a little bit of your question?
Yeah, no, that was great, and I really appreciate the bringing in of Zika and Ebola. I think it shows a lot of contrast in the different types of viruses and what's going on in the world. So thank you.
Excellent, thanks. Lucas.
Yeah. So in terms of like improving our our responses, like locally or even nationally, like would you say that the most important part, or like where would you say is the most important part of kind of the chain of reaction in terms of how we might respond to a threat that like you guys find or some other analytic people find? So like would it be like national? Would it be like some legislative action that creates a response that's like ready, or would it be something more like arming the hospitals earlier?
Well,
good question.
That's a great
good question.
And it actually goes back to FEMA's old guidance. I mean, FEMA's been saying this for years, is resilience is really at home. We have to have local leadership, and if you have local leadership taking ownership, that is your best scenario, really, with support from the federal government, as opposed to everybody counting on the federal government to be sort of this big brother divinity that tells you when, here's your information and you will act on it, kind of thing. If you do that approach, you're going to be late to respond. And when you're late to respond to these kinds of things, it's kind of like being a firefighter, the more the house is going to burn, the longer you take to engage, right? And so, so I've come around after 25 years of doing this. I've really come around to the viewpoint that, you've got to support the local critical infrastructure at the front line, but then they have to too see the value of you participating and warning to support them, right? And then that becomes some degree of a funding transaction, whether it's supported through local government grant or state grant or a federal grant that's dispensed to the state and local governments, that kind of framework, or a commercial engagement, or both. And I think the model that I've always looked to really is the weather service, right? The meteorological service, and how that there's a public and a private component to that. I think that's really what we're looking at here, is we're looking at essentially the privatization of this function, because there's a limit to what the federal government can do, and there's a limit to what we can expect people to be able to do in reaction to that information. So Lucas, what I would maybe point to as another interesting case study is Hurricane Katrina, right? And that very robust debate around who was responsible for the impact in New Orleans. Mm-hmm. New Orleans, the city, the county, the state, the feds, all of them. We don't want to get in the blame game. It's more of a sterile assessment of who really should have led that response. Now clearly a locality can get overwhelmed, and in some cases very easily, right? So, but how do you build the framework that supports that locality? But the locality is the one getting the first contact with the threat, right? And so that's the hard part.
Okay, cool. Thank you.
So one thing to remember, Lucas, and I think you bring up a really good point, is that warnings are only as good as what's on the other end of the warning. So warnings don't do you much good if the organization that you're warning doesn't know what to do with the information if they get it. So one thing that Dr. Wilson was very good at when he targeted warnings to the critical care infrastructure, that they knew specifically what this meant. This meant, they needed to look for these cases. They had actions they could take in response to that warning. But as you well know, probably when they warned you in school, it was like, okay, I'm warned, what am I supposed to do about it?
Yeah.
So that's one of the challenges here. When the federal government puts out warnings and they say, raise the threat level up, everybody has to be on guard, or it doesn't mean anything to an individual on the ground.
Right. Okay. Yeah.
Yeah. And Lucas, I had that experience. I'll never forget it. It was a painful learning experience, but I had to give the warning intelligence on Ebola in West Africa to our local folks here. And almost universally, the reaction was shoot the messenger. And we really don't appreciate listening to this because we don't really know what to do with it. And CDC hasn't given us any guidance yet. So that was an example where, I made a decision to say something and then I regretted it because it didn't really necessarily help. I don't know. I mean, maybe it sensitized them to pay really close attention to the issue and really go and seek information from CDC. But in terms of really concrete actions, to this day, I don't know what anybody did with that information.
Yeah, that makes it really challenging. Perhaps, Jim, you can give us a little bit more information. We moved through the pandemic, right? We got through the early stages, which, as you rightfully pointed out, was a garbled mess in the beginning. But we've moved through various waves of this. We are now dealing with substantial number of cases and disastrous situations in India, also the same in Brazil, and yet the United States seems to be coming out of it. So when you look at your warning signals now, how do we contend with things are getting better here, they're getting worse in other parts of the world? What are we looking for to know whether or not the world's staying on track to get past this pandemic, or whether we're going to wind up back in another wave of this in the next few months?
Well, we're looking at Sentinel sites of interest. So Israel's a great example, right? So one of those world leading per capita vaccinators. The Navajo Nation is, as you know, has long been a leader in that as well, and relevant to North America. So we're looking at these sites that, especially with Israel, that is connected to the rest of the world by air traffic, right? And because of their physical location, where yes, they're vaccinating. What's going on with their COVID activity level? It seems like it's been dramatically mitigated. We believe in part that's due to vaccination. It could also be because of increased UV index. That's a seasonal phenomenon. But what's interesting to us is to watch these sites that have either gotten hit really hard on the front end, like Sweden, Lombardia, Italy, and then later also had a vaccination program going on. Then they come in and report, hey, we just had P1 from Brazil get introduced here, or B117 from the UK. These variants of concern have been introduced, and then watch what happens to those countries. Are they seeing resurgence? Are they seeing further filling up of their infrastructure with cases? How are they able to weather that, right? Or are they protected, right? And so we're looking at areas of the world where, it's kind of interesting. The US, to some extent, is kind of an island. We ever since the 1700s, we always had this island mentality, that everyone else's problems is their problem, right? Which is delightfully parochial. But, when, for example, when it was coming out of Wuhan and spreading in China, we were watching Hong Kong and Singapore very closely because we knew that it was going to likely go there first. And we were going to get our first taste of what a comparable healthcare infrastructure, to the US, what they were going to experience for real, right? So it's sort of a validation of what the folks in Wuhan were saying. And it was misleading, actually. So the first contact point for Hong Kong and Singapore, they saw a fairly mild wave that seemingly was manageable, right? What we didn't realize at the time was, the virus was mutating. And it was mutating. It was also misleading because the scientists were saying that it was mutating at a slower rate than influenza. And so that led us to think, well, okay, if it doesn't adapt as quickly as influenza, then maybe we can wiggle ourselves out of this. It won't be so bad after all. And then when it hit Lombardia and completely blew out their infrastructure there, it wasn't until months later, and we escalated our warning at that time. We said, no, we're not going to get out of this. This is going to be a mess. It wasn't until August, so we're talking like late February, early March. It wasn't until August that we found out that the virus had indeed mutated. The spike protein had stabilized, and now the virus was transmitting more efficiently. And you classically don't ever find that out until after the fact, right? So going forward, as we're looking for what's going to happen next, we're repeating that operations pattern where we're looking at Sentinel sites, looking to see, okay, they're doing roughly the same thing we're doing. They're vaccinating. They're about the same per capita rate. They've had some introductions of variants of concern. Turns out they didn't really generate another wave of demand. So far, so good. And so the future, if we get through if we get through summer and we don't see a resurgence wave here in the US, we're going to pretty good. We get through the fall and no resurgence wave, even better. If we get through January, February, no resurgence, well, then we're going to sort of say, all right, it's time to get on with our lives for real now. Like, really, let's put this behind us and try to pick up the lessons learned and move forward.
Excellent. Thank you. I appreciate that. That's a little bit of good news. So perhaps we will be
optimistic.
Cautiously. That's good, because for many months, Jim, you were anything but optimistic. So Cole, do you have any follow-up questions?
Actually, yeah. So kind of on this note, you were talking about the resurgence and how it gets better and better over time. I know a lot of people are looking to the future and expecting, when are things going to get normal? And I think especially for students, we kind of want to be back full time and everything. Just based off of the statistics right now and everything, how do you think things are going to look like in the future? Do you think people are going to wear masks in grocery stores for the rest of the time, or school is going to be fully in person, or there's going to be distance options? What do you think are going to be the effects of this? So.
Well, that's a great question, and it relates to local perception of risk, right? So if you live in a community that has gone for months without seeing any resurgence, you're going to see a pretty big public push to get on with things, even if our vaccination levels are not optimized, right? And so then that introduces a little bit of consternation, because if you then see resurgence after you've gone back to school, after we relaxed, right, then everybody's going to accuse you of doing the wrong thing, right? And so it's darned if you do, darned if you don't, right? To me, and this has been really hard to do because I'm a human too, you kind of have to be Mr. Spock and sort of say, okay, listen, I'm here to give you the warning. I'll give you what we're worried about, but it's up to you to make the decision, you community, right, as to what you want to do with that information, right? If your interpretation of what I said to take all the masks off and go run around in the street without any protection and go have a rock concert together without any protection, then probably unwise, but that's your choice, right? But we did tell you that might not be the wisest thing to do just yet. Like, we got to be patient here, right? As far as school for next year, I'm actually cautiously optimistic. but my optimism may not be shared by the teacher union, right? So the teachers, many of the and I love the teachers, right? So I'm a pediatrician, and teachers are part of our team of care for kids, right? And so I very much respect their concerns of their risk exposure, right? So it's not just the students, that we're thinking about, right? We know darn well that the risk profile for kids is not the same as older adults. We know that. But the issue is we're mixing kids with older adults in some cases, right? Who may themselves have hypertension, diabetes, might be overweight, and therefore at risk of bad outcomes with COVID, right? They may not be healthy enough to be resilient. So we just, there's a lot going on. And so it's a conversation, and it's a conversation where folks just need to listen to each other and listen to the concerns. I think vaccination, my hope here is we'll have several very visible examples throughout the world where vaccination just simply has stopped, significant transmission. I think it'll still be with us for the years to come, but I'm talking like no more explosive overwhelming of hospitals, right? And if we can have a few of those examples noted, as well as local awareness that we haven't seen anything in months, I think that'll reassure people, and you'll be able to kind of get back to the good work of being a student. I will say that clinically as a pediatrician, I need to acknowledge that I've not seen so much depression in my entire career. So all the concerns about the mental health aspects of being denied access, physical access to school, listen, those are real. And I have not had to treat so many kids with antidepressants in my whole career. And a lot of these kids are badly depressed. We're talking, having thoughts of wanting to hurt themselves kind of level of depression. And that's deeply concerning. So we as a species, we need to find a way through this mess to come back together again somehow. If it means that everybody's got to wear a mask for a little while longer, okay, but we do need to sort of find our way through this, if that makes sense.
Jim, I think you hit on some really important points for Cole, which is returning to life as normal, whatever normal is, will involve dealing with these issues, long hauler impacts from people who got COVID and have long haul symptoms, the depression, the mental health issues that we've had associated with that. Are also things that we're going to have to recover from. So I'm going to let you have the last word, Dr. Wilson. And you're talking to the next generation. What should they be looking for when they go off into the world and they're thinking about issues about health security and things that could impact their lives undoubtedly in the future? We may be getting out of this pandemic. Maybe we wind up in another one in less than 100 years. What are your thoughts, and what opportunities are there out there for them to make a difference in the world in dealing with these issues?
Well, I guess I'll sort of maybe respond to that by having a more personal response, and in saying that the way I approached my career was a very simple question: that if I'm 80 years old someday, looking myself in the mirror, am I going to feel good about what I did with myself? Do I feel like I made a difference? Because you can't take the money with you when you go. You can't take a lot of this material stuff with you when you go. Can you feel good about what you did with your efforts, right? And certainly I've made mistakes multiple times through my career, but at least my heart is in it to help, and to help protect our country, help support the rest of the world in protecting their, all the other countries, right? Even countries that are maybe, misbehaving at times. But, we want to be helpful, right? We want to come together as a species. And I may not be running around driving a Porsche or anything like that, but that wasn't really my objective. My objective was, I want to look myself in the mirror and feel like I made a difference. I'd like to know that my colleagues, feel like I did the right thing. I like my daughters to know, or feel that I did the right thing to the best of my human abilities. And that is truly, at the end of the day, I'm able to pay my bills, what more could I really ask for, right? And so to have the privilege of engaging in this kind of an issue with so much at stake, it's been an honor.
Well, thank you for that. Thank you. We are at time, so thank you, Dr. Wilson, for sharing your thoughts and your insights. Thank you, students, for joining us, both live and virtually. We appreciate that. Dr. Wilson is local, as you said, so if you have follow-up questions or things that you would like to understand more about his work, I will be happy to connect you to him. And I appreciate your time today. And I wish you both well, and everybody, all the students, well in their next endeavors, and look forward to having you join us again for thoughtful discussions in the future. So thank you.
Yep. Thank you, everybody. I really
Yeah.
appreciate it.
Thank you so much for putting this stuff together. And also hi to everyone watching this after the fact.
Thank you for joining us. It was a pleasure.